dim sum, correct? So you choose what you want to eat, right? Okay, so is there something that you want? Maybe in this case, I will choose only because I just want to start with the most basic digestible meal. Okay, so we'll start off with a very simple eye movement analysis. Okay, and then after that you can choose what you want to eat. Okay, so for eye movement analysis, okay, I always use a paper and pen to draw the eyes and the movement of the eyes, and I represent the eyes with 2 eggs and the arrows. Okay, let me illustrate. If you are asked to look to the left, okay, so this is what your eyes are doing, right? Right? Yes? Your eyes are doing this. So all the eyes are looking to the left now. All looking to the left. All look to the left. Okay? Your eyes are looking to the left, not your head. Eyes. Okay? So you will draw the diagram like this, and then you will connect each of these arrows to its relevant neurological structures. Right? Lateral rectus goes to 6th nerve. Medial rectus goes to 3rd nerve. Okay. Then after that, we know that this person lives in the pons. This person lives in the midbrain. Right? So for this person to talk to this person, you need a communication. The communication is the medial longitudinal fasciculus. Okay? So now you notice there is coordination of eye movements to the left. Coordination of eye movements to the left. So let's analyze this patient's eye movements now. Okay? He's going to look to the right, and there is absolutely no problem looking to the right. When he looks to the left, one eye is moving and the other eye is not moving. Okay? Now, if you were to draw the diagram, it should look like this. This eye is moving, this eye is not moving. So that color red means not moving. Correct? Okay. So then you connect the arrows or the lines. Okay? And then you know that for that patient, when he was looking to the left eye was moving, the right eye is not moving. The reason for that could be any of these. It could be a problem in the muscle. The muscle is not moving because there is something restricting the muscle. For example, thyroid eye disease, fibrosis of the muscle, entrapment of the muscle, orbital fractures. Somebody punches the patient's eyes. There's a fracture in the orbit. The orbital bones trap the muscles. Eye is not able to move. So it could be a localized muscle pathology. This can easily be neuromuscular junction problem, like myasthenia gravis. Okay? It could be isolated third. Okay, and then you should know if it's isolated third, the pupil may be abnormal. The elevation should be abnormal. Depression may be partially abnormal. Okay, and there should be ptosis. So you can look for that. And finally, it could be a lesion in the communication between the two nuclei. Nucleus of the third nerve and the nucleus of the sixth nerve. So this is known as internuclear ophthalmoplegia. So number 1, number 2, number 3, number 4. 4 different possibilities. Okay? 4 possibilities. So you have to go and examine the patient for muscle pathology, clinical exam, thyroid antibodies, orbital scans, neuromuscular junction tests, repetitive stimulation tests, single fiber EMG, acetylcholine receptor antibody, tensilon tests, ice-pack tests. Look for third nerve abnormalities. Look for signs of internuclear ophthalmoplegia. And then you can be sure which one of the 4 is the correct diagnosis. Okay? So in your career, you will see all 4 problems. It could be muscle, neuromuscular junction, third nerve, or internuclear ophthalmoplegia. So you have to be systematically rule them in or rule them out. Okay, now, for the more advanced doctors in the audience, I'll show the picture again and show you, is there anything else in this picture? Is there anything else in this picture that tells you that one of the 4 is more likely? Okay, can you ask that question? Is there one of the 4 that is more likely?
Thì thầy hỏi là một trong 4 cái vị trí thầy liệt kê nãy là cái bó dọc trong rồi dây 3 tiếp hợp thần kinh cơ, thì cái nào nó có vẻ phù hợp hơn?
Very nice. Beautiful. Vertical nystagmus is 100% localizes to the brain stem. So the only thing here that's brain stem is, so that's a good sign, number 1. Number 2, anybody else sees anything else? Not really. The ptosis is on the slightly on the other side actually. So no ptosis. Vertical nystagmus. What about this eye? What's happening to this eye? There's also a nystagmus in this eye, right? This is known as the abducting nystagmus, which is more obvious in this patient. Same problem. Look carefully at the abducting eye. Look carefully at the abducting eye. I'll play it again. Look carefully what happens there. There is an abducting nystagmus. That is very typical for internuclear ophthalmoplegia. It can be seen in other conditions, but if you don't see it, it's very typical for internuclear ophthalmoplegia. Let me explain why. You see this nystagmus in the abducting eye. The reason for that is very simple. The stimulus from the brain is coming and making the eyes move to the left. But the signal to this eye is blocked by a lesion here. It's blocked by a lesion here. But the signal is getting through to the other eye. Correct? Signal is getting through to the other eye. What does the brain do? It is confused because this eye is still not moving. So it sends more signals to the eye. More signals are blocked here. More signals are blocked here. But the more signals are still going through here. What does the brain do now? Send even more signals. Okay? And even more signals are going through to this side, but still blocked here. So this guy is getting 0 signal. 0. This guy is getting 3 times, 4 times, 5 times the force that's required. So what's going to happen to the eye? Overshoot, come back. Overshoot, come back. Overshoot, come back. So in other words, the stimulus coming from the brain is too much for this eye, it's too little for this eye because there's block. So this eye keeps overshooting.
Thầy lý giải tại sao nó có cái nystagmus khi mà liếc ngang của cái dây sáo, thì cái tín hiệu mà từ trên não nó từ dây sáo nó bắt qua dây 3 thì nó bị block lại, do đó là có cái sự không đồng trục giữa hai mắt, thì cái não nó tiếp tục nó kêu cái con mắt dây 3 nó đi ngang qua, đi vô trong, thì cái tín hiệu từ não nó đi xuống nó càng nhiều hơn tới cái dây sáo còn bình thường, thì nó sẽ làm cái dây sáo nó overshooting, nghĩa là nó đi qua rồi nó sẽ giật trở lại, đi qua rồi giật trở lại để nó tăng cái tín hiệu. Hồng là nó muốn cái tín hiệu nó đi qua cái bó dọc trong để tới dây 3 đối bên, do đó là mình có cái nystagmus. Yes sir.
So everyone understands? Okay, so now let's watch this patient again. You can see this signal is not enough, so no movement. This one is. So this abducting nystagmus tells you that this patient's problem is more likely to be internuclear ophthalmoplegia. It's less likely present in third nerve, neuromuscular junction problem, and muscle pathology, but very typically seen in internuclear ophthalmoplegia. So, vertical nystagmus, abducting nystagmus are all signs that this is internuclear ophthalmoplegia. But there is a number 3 sign, the third sign that tells you this is internuclear ophthalmoplegia. And that is the head tilting to the left, this eye going up, and this eye going down. Do you see that? His head is tilted to the left, the right eye is up, and the left eye is down. This is known as skew deviation. Skew deviation, very important neurological sign because it points, skew deviation points to the central nervous system. Skew deviation points to the central nervous system again. So, 3 reasons why the diagnosis is not it's okay. It's not muscle, it's not neuromuscular junction, it's not isolated third, but it's internuclear ophthalmoplegia. Number 1, vertical nystagmus. Number 2, abducting nystagmus. Number 3, skew deviation. Okay? Now, if you want to know what skew deviation is, so this is the final answer, right? If you want to know what skew deviation is, you have to choose then we will talk about skew deviation. Okay? It's a very interesting anatomical understanding. The anatomical understanding of skew deviation is very interesting, but it takes a while to go through. Okay, so we have decided that this patient's problem is most likely in the medial longitudinal fasciculus. The medial longitudinal fasciculus is traveling from here, from the pons all the way to the midbrain. Okay? So it's a very small lesion. The radiologist sometimes can miss the lesion. It's a small dot. So you need to tell the radiologist where to look for it. Okay? So normally I ask them to find this particular cut where you will see this double, it looks like a W, the W sign. What is the W sign? That is the facial colliculus. The motor neuron, the facial nerve is very big. So it swells the brainstem. And that is the 2 things that are hanging. Looks like W. Okay? When you see the W sign, that's where the 6th nerve and the 7th nerve nucleus are. Okay? And then from the nucleus, right in the midline, it has to travel from the nucleus, it has to travel across to the other side. Okay? And that is in the center is the medial longitudinal fasciculus. So it will be a small, very small dot in the pons or midbrain in this particular location. Okay? So you have to look carefully. Most of the time in an acute setting, this is stroke. If you are working in France, some of you will be working in France, where multiple sclerosis is common. This is a common location for demyelination to occur because it's a very highly myelinated tract, medial longitudinal fasciculus. It's a very fast tract. So myelin disorders often affect this particular area. Okay, I'll pause for a few seconds for you to explain.
Thầy, cái sang thương này ở vùng trung não thì hay gặp nhất là đột quỵ, là nhồi máu não. Nhưng mà với các cái chủng tộc phương Tây á, thì nếu mà ai mà thực hành ở Pháp thì nó hay gặp MS. Thì cái vùng này là cái vùng dây thần kinh, sợi trục thần kinh giàu myelin và nó rất là dễ có tổn thương đối với MS.
Great. Okay. So we have eaten the egg tart. So we have taught you how to draw two eggs as the eyes to understand eye movements. So now you'll put this into practice. Okay? By analyzing this patient's eye movements. This patient is asked to look to the right first, and she does it very well. Then she's asked to look to the left.
Look to the right. Now look as far as you can to the left. Right. And as far as you can to the left.
She's not moving the eyes to the left. So if you draw the egg diagram, both arrows should be red. And then when you connect it like this, it becomes so easy. Because you realize, if you put a lesion here, this will be red, this will not be red. You put a lesion here, this will be red, this will not be red. You put a lesion here, this will be red, this will not be red. But if you put a lesion here, both will be red. So, let's put a lesion there. And then you realize the patient is not able to look to the left. So, the sixth nucleus is also known as the lateral gaze center because it coordinates movement to the same side. So, if I can't look to the left, it could be a problem in the sixth nucleus because the stimulus starts from here and transmits to both sides. So when this is damaged, both will become red. Both will become red. So this is lateral gaze palsy from a lateral gaze center problem. There's no head shaking there. So you want to explain? No? No.
Thì ông thầy nói là cái hai con mắt bệnh nhân này không nhìn qua bên trái được hết. Thì cái định khu của mình tại thân não thì cái vị trí khả dĩ nhất là cái nhân dây 6. Tại vì khi mà tổn thương cái nhân 6 đó thì nhân 6 này thầy nói là nó nằm trong một cái tổ hợp gọi là cái trung tâm nhìn ngang ở cầu não. Thì nếu nó tổn thương thì cả hai con mắt đều không thể nhìn cùng một bên được hết. Thì đây là một trong những cái vị trí có thể tổn thương trong tình huống này.
Okay. Now, so far, this is in the brain stem. Now, brain stem is reflex. There is no voluntary control in the brain stem. It's reflex. So, the word in English is volitional control or voluntary control. Where does the voluntary control, where does it come? For example, today I wear this shirt. Today I want to eat croissant, right? Where does that come from? Free will is from the frontal lobe. Frontal lobe decides volition, everything. You want to be a doctor, you want to be an engineer, You want to marry the lady, don't marry the lady. Drive a BMW or Toyota. It's all from here. Frontal lobe. So eye movements, I want to look to the left. I want to look to the right. I want to look up. I want to look down. Voluntarily comes from the frontal lobe. Brainstem is reflex. You hear a sound, you move. That's reflex. Voluntary is I want to look to the left. I want to look to the right. That is coming from the frontal lobe. But the signal from the frontal lobe is crossed. So the right frontal lobe controls the left 6 nucleus. The area in the frontal lobe is called FEF, frontal eye fields. The right frontal eye field tells the left 6 nucleus, look to the left. The left frontal eye field tells the right 6 nucleus, look to the right. Okay? So, now you realize that this lady's inability to look to the left can be here, but can also be here. Right? For example, when you are in the hospital, you see a middle cerebral artery infarct patient. Middle cerebral artery infarct on the right side will affect the right frontal eye field. Patient is not able to look to the right. What happens to the patient's eyes? Cannot look to the left. Cannot look to the left, so the eyes will drift towards the right. So you've seen that almost every day in the hospital because this cerebral infarctions is common. So frontal eye fields on the right side and left 6 nucleus will give rise to the same inability to look to the left. So this lady's problem could be either in the right frontal eye fields or in the left 6 nucleus. Everybody okay? Do we need to translate? No. No? Everybody okay? You guys are okay by the back? No? Okay, maybe just tell them very quickly. 2 possibilities for right frontal eye fields and left 6 nucleus.
Một cái khả năng khác trên bệnh nhân này là có thể nó tổn thương cái diện mắt của thùy trán. Thì chúng ta nhớ là cái chủ động, cái vận động mà nhìn sang một bên đó là vận động chủ ý, thì nó xuất phát từ cái thùy trán đối bên, nó nối với lại cái trung tâm nhìn ngang ở cầu não cùng bên. Thì bệnh nhân này thì có thể là có 2 vị trí tổn thương nào nó cũng có thể giải thích được cái chuyện bệnh nhân không nhìn sang bên trái.
So, to differentiate between nuclear left horizontal gaze palsy and supranuclear horizontal gaze palsy is what we will discuss now. Okay? Now, why the word supranuclear? Well, if neurologists were in charge, they would call this upper motor neuron horizontal gaze palsy. This is lower motor neuron horizontal gaze palsy. That's what it is. This is lower motor neuron horizontal gaze palsy. This is upper motor neuron horizontal gaze palsy. But because eye doctors like to have different names, right? So they have called this supranuclear and nuclear. It's like when you have brachial plexus lesion, you will call this lower motor neuron weakness of the left arm. And if you have a right MCA infarct, you call this upper motor neuron weakness of the left arm. You don't call this nuclear weakness of the left arm and supranuclear weakness of the, but it's the same. So this is lower motor neuron, that is upper motor neuron. Okay? Everybody okay? Dr. Tree? No. Everybody okay? Yeah, I think you sit behind better. Okay, somebody in the back wants to ask a question. Okay, so how do you differentiate between these two? Well, just like you would do for your arm, Very simple. This patient who's got a lesion in the right frontal eye field will walk into your clinic like this. Left hemiplegia. The patient with a left pontine lesion giving rise to nuclear horizontal gaze palsy will come to you with a right hemiplegia. So as the patient is walking into the room, you will be able to decide whether it's supranuclear or nuclear. That's one. Number two, as the patient comes and sits next to you, you look at the face. You realize that this patient would have upper motor neuron, facial weakness, only here but not here. This patient's sixth nerve is next to the seventh nerve. So this patient will have lower motor neuron, facial weakness of the same side, right? So not only is the side of weakness of the limb is different, but the type of facial weakness is also different between supranuclear and nuclear gaze palsy. Okay? And then lastly, you touch the patient. As the patient comes to you, you have to touch the patient. As you touch the patient,
Right at the camera, please.
you put the hand on the head and you rotate the head.
So with the VOR, there's no real change.
So this is the Doll's reflex or the VOR, vestibular ocular reflex. Vestibular ocular reflex. Okay, so Dr. Z there was using the vestibular ocular reflex to differentiate nuclear from supranuclear gaze palsy. So how do we explain the mechanism of vestibular ocular reflex using this diagram? Because so far we have third nerve, we have sixth nerve, we have frontal eye fields, we have medial longitudinal fasciculus, but where is the eighth nerve? The eighth nerve is not connected to this pathway. If the eighth nerve is not connected to this pathway, how can we use the vestibular ocular reflex? No, actually the eighth nerve is connected to the pathway. How is it connected? Well, very simple. If you remember anatomy, you have semicircular canals on the left side in your mastoid bone and semicircular canals on the right mastoid bone. These semicircular canals are filled with fluid, right? So when you turn your head, what happens to the fluid? The fluid is moving, right? You have many semicircular canals, horizontal, posterior, and superior, right? So these semicircular canals are moving according to the direction of the head. So this signal is picked up by the semicircular canal and transmitted to your sixth nucleus. But how is it transmitted? Well, very easy. When I turn my head to the left now, I'm looking at the back of the room, but I'm turning my head to the left, right? Did you notice what happened to my right eye? My right eye is abducting, my left eye is adducting. Now I turn my head to the other side. What did automatically, reflexly, my left eye was abducting, my right eye was adducting. Okay? So that means there is already a reflex movement, right? So how do we work out this reflex movement? Very simple, right? So if I move my head to the right, my left eye is abducting, my right eye is adducting. Now, for that to happen, which nucleus must be active? Which nucleus must be active? Left eye is abducting, right eye is adducting. Which nucleus? Six nucleus on which side? Left side. See, my left eye is abducting right eye. So my left six nucleus there. Which here is more active? Okay, now as you move the fluid on both sides are moving. Correct? Which side is getting bigger signal? Well, if you think about it, very simple. We go to the ocean now, go to the beach. Go to the beach at the ocean. The currents are very strong, but you wouldn't know until it hits the wall, which is the beach. When it hits the beach, you get waves. Now, as the water is moving back, what happens? Very quiet. Right? So in other words, when there is movement towards something, hits against the wall, that's when there will be more waves. So here, the fluid is moving on both ears. This side is moving. When I move my head to this side, okay, this one is moving away from the wall because it's a semicircular canal. Fluid moving away from the wall. This one moving towards the wall. Because when I move my head this way, this is moving, fluid is moving away from the wall. This is moving towards the wall. So as it hits the wall and comes back, it's going to cause waves. This one is moving away from the wall, so therefore there will be less waves on this side. So this should tell you that when I move my head to the left, my left eye abducts, right eye abducts, which means my left six nucleus is active. But the ear that is more active is the right side, the opposite side. So therefore, this should tell you that the eighth nerve should be connected to the contralateral 6 nucleus. Contralateral 6 nucleus.
Thì xin tóm tắt lại ba cái cách. Thì nãy mình nói là có hai cái vị trí tổn thương, có thể là trên nhân, tức là vị trí của thùy trán, hoặc là ở tại nhân, tức là vị trí tại cầu não. Thì có ba cách để phân biệt. Cách thứ nhất là mình dựa vào những dấu hiệu đi kèm theo. Nếu bệnh nhân mà tổn thương ở trên thùy trán á, thì cái tổn thương của, thí dụ như bệnh nhân có yếu nửa người thì sẽ là yếu nửa người phía bên cùng bên với lại cái bên mà bệnh nhân không nhìn được. Thí dụ trường hợp này là bệnh nhân yếu nửa người trái thì sẽ nghĩ đến tổn thương ở thùy trán. Nếu như bệnh nhân yếu nửa người phải thì sẽ nghĩ đến tổn thương ở cầu não. Và dấu hiệu thứ hai là mình sẽ dựa trên cái liệt mặt của bệnh nhân. Nếu như bệnh nhân liệt mặt và liệt mặt trung ương ở bên trái thì nó sẽ nghĩ đến cái tổn thương ở trên thùy trán. Còn nếu như bệnh nhân liệt mặt ngoại biên ở bên trái thì sẽ nghĩ đến tổn thương ở cầu não. Và dấu hiệu thứ ba là mình dựa trên đánh giá những cái phản xạ của thân não, mà cụ thể là phản xạ tiền đình mắt. Thì trong trường hợp này á, thì cái dây số 8 ở bên phải nó sẽ được kết nối với lại cái trung tâm nhìn ngang ở bên trái của cầu não. Thì khi mà chúng ta làm xoay đầu bệnh nhân á, thì cái dây 8 ở bên phải nó sẽ trong trạng thái kích thích và nó sẽ kích thích cái trung tâm nhìn ngang ở bên trái. Thì nếu như mà mình làm cái phản xạ EVOR này mà con mắt nó không có liếc qua được á, thì chứng tỏ là nó đã tổn thương cái cung phản xạ này, thì điều đó chứng tỏ là cái tổn thương nằm ở cầu não. Còn trong tình huống mà frontal, tức là tổn thương thùy trán á, thì cái phản xạ này nó sẽ còn bảo tồn.
So to differentiate nuclear and supranuclear case palsy, not only do you need to use the site of weakness, the type of facial weakness, but you could also use the vestibular ocular reflex, because if the lesion is here, the vestibular ocular reflex will not work. But if the lesion is in the frontal eye fields, when you move the head, what happens? The eye is able to overcome the problem using the vestibular ocular reflex. So that's what you do when you are seeing patients with middle cerebral artery infarct. If you take the head and rotate it, Even though the eyes are pointing to one direction, when you move the head, the eyes will be able to move to the opposite direction. Will be able to move to the opposite direction. Okay? So, in this particular case, if you look carefully,
Right at the camera, please. Right at the camera.
the weakness is not overcome with the doll's response. So therefore, this patient's problem must be here and not there. So this patient has got a left 6 nucleus lesion or left gaze center problem, not a right frontal eye field problems. So this is how you differentiate nuclear and supranuclear lesion for horizontal movements. Okay?
Right at the camera, please.
Now, there are other uses for this. I'm very sure that as neurologists, you'll be called to certify brain death, otherwise known as brain stem death. What do? You do the ice caloric test. When you inject ice water into the ear, ice water is 0 degrees. The fluid inside the ear is 37 degrees. So the ice water is going to make the fluid colder than blood. So what happens? That will make the fluid move, right? It creates current because of the difference in temperature. When that moves, your eye will then move either towards the cold water or away from cold water. That is the basis of the ice caloric test. If that is present, you know your brain stem is intact, the patient is not dead, you cannot take the organs. Right? But if you inject ice water and the eyes are not moving, then that's one more test to say that the brain stem is not working. So that is another application of the same anatomy. Do we need to translate? Just to say ice caloric testing.
Ở đây thầy nói về một khái niệm, đó là chúng ta đôi khi được đánh giá chết não á, thì cụ thể là đánh giá chết cái thân não á, thì chúng ta sử dụng cái test caloric nhiệt bằng cách là chúng ta kích thích cái tay đối bên bằng cái nước đá. Thì nếu như mà tiêm nước đá vô mà con mắt nó không có chuyển động, tại vì biết nước đá vô thì nó sẽ làm thay đổi cái tính chất của cái dịch ở cái ống máng khuyên, cho nên là nó sẽ tạo ra cái sự thay đổi trên cái tiền đình bên đó. Thì nếu như mà chúng ta chích nước đá vô mà nó không có tạo ra cử động mắt á, thì có lẽ là cái đã có tổn thương của cái cung phản xạ ở thân não rồi, và thân não đã chết rồi. Còn ví dụ như chúng ta sử dụng thuốc nước đá mà nó vẫn còn cái phản xạ tiền đình mắt á, thì là nó sẽ, tức là thân não chưa có chết.
Okay, now so we have understood how to work out supra or nuclear lesions for horizontal movements. Then the next question you will be asking me is, what about this? Vertical movements. Okay, there will be nuclear and supranuclear influences. But again, if you want to ask, where is that? Somewhere here. Yes. You have to choose this. If you want to know what is the basis of vertical movements, nuclear and supranuclear. Very similar, but slight differences. Okay? Okay. Okay, I'm going to pause now before we go to the next dim sum. You want to just summarize and ask if there's any questions before we go to the next dim sum, which is going to be, I'm going to segue to this.
Có ai có câu hỏi khác không? Tại vì chúng ta sẽ chuẩn bị qua cái phần trung tâm nhìn rộng. Có ai có câu hỏi về tất cả những cái phần thầy vừa mới nói không?
Okay. Question.
Okay, move on, sir.
No question?
No question.
Okay. Okay. So now we're going to go to this. Now we have already understood the connections here, and we have understood the connections for the eighth nerve. The eighth nerve, semicircular canals, are connected to the contralateral 6 nucleus for the eye movements to be reflexly controlled. So in other words, when I move my head to the left, this side is more active. Signals go to the right 6 nucleus, right eye abducts, left eye adducts. When I move my head to the right side is more active. That signal is going to the left 6 nucleus, left eye abducts, right eye adducts. When I'm looking straight at you, both sides are quiet, so my eyes are steady. But both sides are quiet, but they are still alive. The semicircular canal is still alive. It is quiet, but not dead. But if I come and damage one side is dead, the other side is alive. So previously when I move my head to the right, this side is active. When I move my head to the left, this side is active. When I'm steady, both sides are quiet, but not dead. So when they are quiet means they are firing at the basal rate. Basal in English, B-A-S-A-L, means baseline. Baseline, right? So when I move more to the right, more signal. When I move more to the left, more signal. But when I'm looking straight, but now I've come and killed this one. This is dead, 0. This is basal, baseline. But now the brain is thinking, oh my God, this side is more than this side, because this is 0 now. So what's going to happen to my eyes? It's going to move as if my head is turning to the left, but my head is still straight. So what's going to happen to my eyes? Looks towards the door there. But then because I'm alive, I'm conscious. So what will happen to me? I say I don't want to look there. So what will happen? I'll bring it back. But the signal is still firing more than this side. This side is dead. So what's going to happen? More signals go to the contralateral 6 nucleus. Right eye abducts, left eye adducts. Move to that side. But I bring it back. Slowly drift back again. Bring it back. Slowly bring back again. Bring it back. Okay, drift back, bring back. Drift back, bring back. Slow phase, fast phase. Slow phase, fast phase. Slow phase, fast phase. What is this? Nystagmus. Correct? So this is classic peripheral nystagmus. Okay? And that is the mechanism of peripheral nystagmus, because one side is not functioning, one side is functioning normally. The normal side makes the brain think that this side is more active, so the eyes are going to drift as if your head is turning to the left. But because you're conscious, you're bringing it back, and the fast phase is your correction. Okay? Now, this is peripheral nystagmus, right? What are the key features of peripheral nystagmus? Well, you're asked to memorize these rules of peripheral nystagmus. But it can all be worked out using this anatomy. First of all, what is the direction of nystagmus? Remember, this side is dead, this side is firing. Eyes are drifting to the right, poke, poke, poke. The fast phase is the direction of nystagmus by convention. The rules of the textbook is you define it by the fast phase. So where is the fast phase beating? Away or towards the dead ear? Away. Rule number 1, peripheral nystagmus beats away from the disease ear. Rule number 2, when I look up, when I look down, when I look to the left, when I look to the right, is there any difference in the firing? No difference. When I am moving my eyes consciously, up, down, left, right, the imbalance is still the same. So if the imbalance is still the same, is the direction of nystagmus going to be the same? Always the same. So peripheral nystagmus is always beating in the same direction. No change in direction of nystagmus according to your gaze. Always unidirectional. Rule number 2. Why unidirectional? Because nothing to do with the eye. It is this firing more than this. So it will always be firing away from the disease ear. Whether I look up, look down, look left, look right, I go this way, I go that way, look down, look here, anyway, whatever I do, it will always be beating in the same direction. Rule number 2. Rule number 3. What is the type of nystagmus you will see? Well, we have 3 semicircular canals. Okay, 3 semicircular canals. One is, okay, if you look at my ear now, one is horizontal, like this. Okay, one is superior and one is posterior. Okay, so it should be shaped like this: superior, posterior, horizontal. Okay, but unfortunately the directions are not exactly superior. Okay, it's slightly tilted to the back. Posterior is slightly tilted down like this. Okay, horizontal is purely horizontal. Okay, so this is the way the semicircular canals are positioned. Okay, now when this part is damaged, all 3 are damaged. Remember, 8th nerve is damaged, so all 3 of them are damaged. Horizontal is damaged, superior is damaged, posterior is damaged. On the other side, all 3 are alive. Alive and firing at baseline. Horizontal, superior and posterior. All 3 are firing. Baseline, basal, right? So, if you think about it, there's 3 here, alive. These 3 are dead. Okay? Now this horizontal and this horizontal, one horizontal is dead, this horizontal is alive, but he's got nobody to oppose him. But this superior and posterior, one is going this direction, one is going this direction, right? These 2 are almost against each other. Imagine they were against each other in this direction. They would have cancelled each other out, but they are slightly tilted. So this will partially cancel this one out because they are almost against each other. But the one that's not cancelled is 100% intact is horizontal, because this side all 3 dead, this 3 all 3 intact. Now this 2, this and this will partially cancel each other out, but this is completely intact. So the direction of nystagmus will be mostly horizontal, but cannot be 100% horizontal because there is a bit of leftover from the superior and posterior. So if you look carefully at the peripheral nystagmus. It's mostly horizontal, but with a hint of a torsion. Not fully circular, not fully rotatory, not fully horizontal, mostly horizontal, but with a little bit of torsion. Okay? Okay. So I'll explain everything and then we will see. So if you look carefully at this patient now, this is a person with left vestibular disease, So, you see that? It's beating towards the right. When he looks to the left, it's also beating towards the right, but much milder, but still beating towards the right. Okay? And if you look closely, it is not purely horizontal, it's slightly torsional. Horizontal and torsional. Not purely torsional, but horizontal and torsional. The reason for that is the three semicircular canals on the left side. The horizontal canal is the most dominant one. The superior and posterior, because of the direction, they cancel each other out. It's like my punch is not overcome by your punch if it is in this direction. These two will be cancelled out. But this two is not cancelled out, right? So that's what happens. Now, the last rule, and then we can ask for translation and questions, is the so-called Romberg sign of the eye. What is Romberg sign of the lip? You all are familiar with Romberg sign? You use the word Romberg. Okay, what is Romberg? Now, if I come to you, doctor, I'm very unsteady, but I walk very well. I walk very well to your clinic, and then I stand in front of you, and then he says, close your eyes, and then I fall. That is called Romberg sign. Why? Because the cerebellum is taking input from the limbs, peripheral nerves through the spinal cord, and taking input from the semicircular canals for the balance. Okay? Now, if there is disease outside the cerebellum, let's say, for example, peripheral nerve pathology or dorsal column pathology, spinal column pathology, the patient has got no sensory input into the cerebellum. So what does the cerebellum do? It uses the eyes. But the eyes are not meant to be for balance, right? But it's using the eyes to compensate. Because the eyes will tell you, pillars are straight, floor is flat, trees are straight, okay? Buildings are straight. So using that, you can balance yourself. But when I close my eyes, cerebellum doesn't know which is right, which is left, which is up, which is down. So what's going to happen? It's going to fall. Right? So that is Romberg sign. Peripheral pathology. But in cerebellar disease, let's say I've got phenytoin toxicity. Okay, my cerebellum is not working. I'll come to you a little bit unsteady because my cerebellum is not working. I close my eyes, I will still be unsteady, maybe a little bit worse. But the difference between eyes open and closed will not be very different because it doesn't matter what input. Cerebellum is gone. So without cerebellum, what does it matter whether your eyes are open or closed? It doesn't know what to do. Balance is poor. So eyes open, eyes closed, very unsteady. But if the cerebellum is intact and it's just posterior column or peripheral nerves, then what will happen is the patient will look very steady. But the closed eyes, boom, it falls. A lot of difference between the balance with the eyes open and eyes closed. That is Romberg sign of the limbs. What about Romberg sign of the eye? If you have peripheral nystagmus, your cerebellum will not be happy because you are this way or this way. Now what happens to you when you see your eyes going like that? You will be vomiting. You will feel miserable. You will be very uncomfortable. What will the cerebellum do? You will try to suppress. But what does the cerebellum do to suppress your eyes? Your eyes have no peripheral nerve. You close your eyes and move. Only your cornea has sensation. Your eyeball has got no sensation. You realize that? Close your eyes and you move. You don't know your eyes are moving. Only your cornea has sensation. So, if your eyes has got no sensation, what does the cerebellum use to know where your eyeball is? Vision. Correct? So it's using vision to suppress the nystagmus. Because the cerebellum is not happy with it. So it will use vision to suppress it. So when you remove vision, the nystagmus will get worse. So just like when you close the eyes, remove vision, patient falls, Romberg sign of the limb. You close the eyes or you remove vision, the nystagmus gets worse, it's Romberg sign of the eyes. This will tell you this is peripheral pathology, not cerebellar pathology. In cerebellar pathology, the nystagmus, eyes open, eyes closed, eyes open, eyes closed, just like your balance doesn't change very much, your nystagmus doesn't change very much. So that is the last rule. Romberg sign of the eye tells you that it's peripheral if it gets worse when the eyes close. So let's look at this man now. So he's got a mild nystagmus to the right. He beats to the right, mix horizontal and rotatory. Worse on looking to the right. When he looks to the left, still beats to the right. But when I do the Romberg sign of the eye, so the nystagmus becomes much more obvious, right? A lot of difference. Eyes open, no nystagmus. Eyes closed, nystagmus. Correct? So this must be peripheral nystagmus, cannot be central. Because the difference between eyes open and closed is like the difference between day and night. A lot of difference with the eyes open and closed. But the problem is, most patients, when you close your eyes, you can't see the eyes moving. Only with people like him, who's got very thin eyelids. Okay, who's got very thin eyelids, where you can appreciate the eyes are moving inside. So it's worthwhile trying. But most patients' eyelids are very thick, so you won't be able to see the eyes inside. So what can you do? You have to remove visual fixation. Remove visual fixation from the patient without closing the patient's eyes. So how can you do that? So this lady has got, so what am I putting on the glass, on the lady? This is known as Harry Potter's magic glasses. It looks like Harry Potter's glasses, right? Do you see that? So without glasses, not much nystagmus, but once I put on the glasses, these are magnifying glasses that the patient cannot see through. Okay, I don't have it here, it's in my bag. These are magnifying glasses, okay, that the patient cannot look through because it's so thick. Okay, so if you put thick magnifying glasses, you can see. Now if you see ENT doctors, they use the commercial version of it, which is very expensive. But I just make the cheap one by getting very thick glasses and putting it into lens. Okay, and then you put it on the patient. Okay, there's a German guy who stole my design and patented. I'm sure he's coming around to Malaysia and selling it, so it's quite shameless.
Who's it?
I'll tell you about it later. Okay, don't buy his things, okay, because he's charging it for himself and it's quite shameless. He comes and gives the talk and he sells it. All you need to do is just go to the your spectacle shop. Tell them to make the thickest possible glass and put it into a lens, and then it's you know, not expensive at all. Okay, so you should do that. Good. Michael Stroop. Michael Stroop, no, you know, he's quite famous in neurology. He's a drug company man. He goes around just for this Peter Saran company. And he's actually well published, but I don't know why he's so shamelessly ignored. So 20 years ago, he was in one of the talks, and then he's spoken. And then now he published in neurology. You Google M glasses, and he called himself M. How to prove? How to prove? Yeah, perfect. Yes. And but he charges I think $70 US. It's called M glasses. He sold it. About $20 in Việt. Yeah, don't buy that. Just make yourself. Okay. So these glasses are useful because you see, look at this. This lady has got vestibular neuronitis. One side of the ear is completely damaged. Okay. You can see she's got very prominent nystagmus. But the moment I take out the glasses, no nystagmus. Nystagmus, no nystagmus. You see the difference? Big nystagmus, no nystagmus. Big nystagmus, no nystagmus. So this is Romberg sign of the eye. So basically, these glasses, without you, when I didn't bring it along, I should have brought it. When you put it on, the patient will say, I can't see anything. It's all very blurred, right? But you can see inside. It's just thick magnifying glasses. If you have a great-grandfather who went for cataract operation, before they had intraocular lens, they used to use lenses like this. Okay? FAK glasses is called. So the optometrists, the older optometrists are very familiar in making these glasses. So nothing too sophisticated. But the thicker the glasses, the better. 20 diopters, 25 diopters, the more the better. Okay, so in summary, peripheral nystagmus is due to disease of the peripheral nervous system, in this case the peripheral vestibular system. It affects the semicircular canals, and because it damages semicircular canals, the other intact semicircular canal firing at baseline makes the brain think that that side is active. So the eyes are going to move as if your head is moving in that direction. If you remember that, then you can work out all these key rules of peripheral nystagmus. Rule number 1, no direction changing. Number 2, beating away from disease here. Number 3, mainly horizontal with a little bit of torsional, which means pure torsional, pure horizontal is central. Okay? And finally, if the eyes open, eyes closed, or with the glasses, without glasses, a lot of difference, this is peripheral. But not much difference, central. So that's how we differentiate from this. Because this is very important, because many of you are neurologists. So, and as neurologists, in acute stroke setting, you have to differentiate acute vestibular disease from acute cerebellar disease. Because both of them will come to you with acute vertigo. For that, what do you use? The HINTS protocol. HINTS. Right? HINTS protocol. What is HINTS? Head impulse, nystagmus, and skew deviation. Right? We talked about skew just now, right? So head impulse, we haven't talked about, but nystagmus we talked about. If the nystagmus is of a peripheral nature, this patient's vertigo is, then after that you have to master head impulse, and you have to learn how to recognize skew deviation, and then you will have a complete understanding of the HINTS protocol, which is more sensitive than the MRI in the first 24 hours to differentiate an acute cerebellar disease from a stroke, from acute ear disease from vestibular neuronitis. Okay? So if you allow me, after translation, I will talk about the remaining components of the head impulse test and the skew deviation, so that you can understand the whole of HINTS. Okay? Okay, I'll pause here for questions or translation.
Get back to the slide to summarize the
em xin được tổng kết lại thì nãy giờ thầy cũng nói khá nhiều. Thì ở đây là chúng ta mô tả những cái tính chất kinh điển của một cái nystagmus ngoại biên Thì chúng ta biết là nếu nó tổn thương tiền đình một bên á, thì cái bên còn lại nó sẽ trở nên là kích thích nhiều hơn, tức là bình thường là cả hai tiền đình đều phát xung ở một cái mức độ nền. Tuy nhiên khi mà nó tổn thương một bên rồi á, thì chỉ còn bên còn lại phát xung thôi, thì nó sẽ dẫn đến những cái sự thay đổi về chuyển động nhãn cầu. Thì nystagmus ngoại biên á, thì thứ nhất là nó đánh, thứ nhất là một chiều, nó không có đổi chiều. Thứ hai là nó sẽ đánh về cái bên không bệnh, tức là thí dụ như tay bên phải bệnh thì nó sẽ đánh về tay bên trái, là do cái chiều kích thích của cái tiền đình nó quy định. Thứ ba là nó kèm theo một cái nystagmus của nó sẽ là vừa ngang và nó sẽ có thành phần xoay, do là cái tổn thương của ống bán khuyên ngang á, thì nó sẽ tạo ra cái thành phần ngang rất là rõ do nó không có bị đối lập lại. Tuy nhiên là cái thành phần của cái ống bán khuyên trên và ống bán khuyên sau á, nó sẽ tạo ra một cái thành phần xoay nhẹ. Thì nystagmus kinh điển nó sẽ là vừa ngang và vừa xoay. Và cuối cùng đó là khi mà chúng ta bỏ cái định thị, tức là cái định thị bỏ cái định thị của mắt á, thì nystagmus sẽ mạnh hơn, là do là con mắt mình nó không còn những cái thông tin để nó có thể suppress cái nystagmus đó. Thì tất cả những cái tính chất này là những cái tính chất của một cái nystagmus ngoại biên. Thì lát nữa thầy sẽ nói về cái test head impulse hay là head thrust á. Rồi, có ai có câu hỏi gì không?
Okay.
Just a small question for you. When you remove the vision, how can the brain knows, get the signal to correct the slow phase of the vestibular? You see, when you close your eyes and the nystagmus gets stronger. But why is that? Because when you no longer have vision to correct the slow phase.
No, see what happens is, when you close the eyes, there's no more cerebellum involved. It's only vestibular, right? Cerebellum cannot control anything because there's no more vision for the brain to know where your eyes is, right? But the head is, move the eyes, the other signal from this side, independent of the cerebellum. Signal is sent to the contralateral 6 nucleus. Right? And the 6 nucleus will abduct eye and adduct the eye. Now this will then induce a reflex saccade back. Reflex saccade. Okay? Reflex saccade. So the reflex saccade, you see, saccadic movements. Okay, you can try this tonight. Saccadic eye movements. We haven't talked about eye movements yet. The different types of eye movements. Saccadic eye movements are this. Now you look at me now. My eyes are here, looking at Dr. Kong, Professor Kong. And then I'm looking at you now. Very fast. Poke, 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 poke. That is saccade. Okay? Very fast movement. Okay? Now, what did I do? I voluntarily moved Professor Kong and this gentleman. I want to move the eye. That is voluntary saccade. There's also reflex saccade. Somebody makes some noise. Boom. I turn my head, but I also can turn my eyes. That's reflex saccade. That wasn't a volition. So saccades have reflex and volition, right? So at night, in the complete darkness, you can still move your eyes. You don't need vision. So saccades are very special. They can be volitional or reflex, just like your arm movement, right? I can volitionally pick this up, but if I pick this up and there's fire there, I didn't move my hand because, oh, it's burned. No, it's a reflex. So the arm, in your spinal reflex, right? There was a spinal reflex. There wasn't volitional because of the burn. You moved it faster than your volitional. But at the same time, I can also move. I don't like to move this. And I pretend to move the same way. So saccades are like that. Saccades and arm movements are similar in that sense. Voluntary or volitional. So you don't need vision for the reflex saccade. So eyes open, eyes closed, okay? The difference is the cerebellum cannot suppress it now. How does the cerebellum suppress? Okay, that what basically it needs to do is program. It needs to program, just like your balance is no good, your cerebellum will use the eyes, okay, to say, okay, I put more force on this side, less force on this side, because everything is straight. But I close my eyes, I'll fall, right? So the same way, the cerebellum will say, okay, this side is working very hard, this side is working, not working at all. What must I do? I must suppress this. And what will I do? I will increase the gain from that right vestibular nucleus. So this is the basis of your compensation after vestibular neuronitis. And that's why we don't like to give metoclopramide, chlorpromazine, beta-histidine and all the rubbish that the drug company wants you to give. Because these will not allow your cerebellum to rebalance. Your cerebellum is powerful enough to say, no signal from this side, lots of signal from this side. What do? I suppress this. Okay, and I will. But to suppress, I need to know what's outside. I need my eyes open, right? So, after vestibular neuronitis, what do we ask the patient to do? Start walking, eyes open, slow movements, like Tai Chi, right? Exactly what we recommend to patients. So slow eye movements, slow limb movements, coordinate, throw the ball against the wall, ball comes back, throw the ball, ball comes back, throw the ball. You use your eyes to teach your brain to increase the stimulus, increase the gain from the right side and reduce the gain from the left side. Make this less sensitive, make this more sensitive. That's what the cerebellum. Cerebellum is a she, for sure. You know why? Because it's tremendous at multitasking. So it's amazing the way she can do a lot of things. Okay?
So what is the origin of the saccadic component when your eyes are closed?
Okay. Saccade, there's a reflex saccade. Reflex saccade is when we talk about saccadic abnormalities. Yeah. You will understand more about how saccades are generated. The saccade generators, volitional and reflex. Okay. Any other questions? Okay. If no questions, then I'll go to the HINTS protocol, right? HINTS protocol tells you that the head impulse, nystagmus and skew deviation, right? The nystagmus is peripheral in nature. So what is not peripheral nystagmus? What is not peripheral nystagmus? Central nystagmus, right? So where is central nystagmus and how does it come about? So if you look at this lady, firstly the nystagmus is purely horizontal, no torsional component. Secondly, when she moves to the right, he beats to the right. When she looks to the left, he changes his mind and beats to the left. So this cannot be peripheral nystagmus. So if this lady comes to you and says, "Doctor, I'm acutely dizzy, this is head impulse," before you do the head impulse, before you do skew deviation, you know straight away she will fail the HINTS protocol. She has got a central disease. She needs to be admitted for stroke. Correct? Because the nystagmus is not peripheral. So what is the reason her nystagmus is like that? Look to the left, beat to the left. Look to the right, beat to the right. Look up, beat up. Look down, beat down. What is the basis of that? Well, for that you need to understand like what we were just talking about. Saccade generation is complex. Okay, it's complex because you need saccade generators in the brainstem in addition to voluntary saccade generators in the frontal eye field. Okay, now to understand that you have to think about your old-fashioned car. Okay, old-fashioned car, because in many countries nowadays all the cars are automatic, but in the old days you have first gear. Why do you need a first gear? Because you're starting your car at 0 velocity, right? So you put in the first gear and you press your accelerator, there will be enough force to start moving the car. As the car picks up velocity, you increase the second gear, third gear, fourth gear. Correct? So this is what your car will do. Now, if you think about your eye now, think about your eye. Your eyeball Especially if you're an eye doctor, you know. You're holding the eye, you know it's heavy. It's not light. The eyeballs are heavy. Who carries the eyeballs? Thin, very thin muscles. Lateral rectus, medial rectus, they are skinny as my arms. Okay, very skinny arms. Okay, medial rectus, lateral rectus, superior oblique, all very thin muscles. Do you think they have enough energy to pull? You see how fast my eyes are going. You saw that? Microseconds. What is the velocity? Microseconds, and what is the degree? This is equivalent to like 50 to 60 kilometers per hour. How does a thin muscle generate enough energy for you to accelerate the eyeball from 0 velocity to like almost 60-70 kilometers per hour, but stop at the right place without screeching sound and never accidentally overshoot and hit the wall, and do this thousands of times, millions of times every day without thinking about it. So who must be involved? Many things must be involved. If you have friends who are engineers, you talk to them, they say this is very difficult. You need multiple machines to engineer this. First, you need an intent. The intent comes from your frontal eye field. I want to move to the left. That intent is not enough. That intent must be converted by your first gear into a force that's enough to lift the eyeball and move the eyeball to very high velocity, just like your first gear. But once the eyeball starts moving, what must it do? It must accelerate, second gear, third gear, fourth gear, and then as it approaches the target, it must quickly slow down and stop exactly at the right spot. Correct? So how do you do that? So whatever we have here is not enough. You need more machines coming in. What are the machines? Firstly, there was a character here that I didn't introduce yet. It's called PPRF. Okay? I've also not introduced our famous, most important structure, cerebellum. Right? Cerebellum must be involved. So let's introduce these two characters, cerebellum and a saccade generator called PPRF. Okay? What do they do? Well, the signal coming from the frontal eye field is taken by a PPRF and says, let's go there. Go there. Hi, Dr. Wan. Signal from the right frontal eye field is transmitted to the other side by, and then goes to the PPRF, and the signal says, go there. First gear. After that, what happens? The second gear, third gear, fourth gear must set in. Okay? So these neurons are responsible for the eye to go and stay where it's supposed to stay. The so-called stay there neurons. Okay? Now, this gets a little bit complicated, but let me show you a diagram. Okay? This diagram is from the textbook. Okay? There is a burst neurons. It's like a first gear. Takes the signal from the right frontal eye field and says, let's move the eyeball. Go there. Lift up the eyeball and accelerate. But as the eyeball accelerates to the target, it must slow down and reach the target. When it reaches the target, it must stop. How does the eyeball know when to stop? Well, if you integrate, okay, the position of the eyeball to the velocity, integrate position to velocity, integrate position to velocity. Remember, mathematics, what is this? Integration, right? So this is a mathematical formula. The brain is like a machine. It uses a mathematical formula to know where the eyeball is and integrates the position of the eyeball with the velocity. So far away, keep going fast. Once it comes close, slow down. So this integration is done by neural integrators. That's why it's called neural integrators. These neural integrators are in the cerebellum. In the cerebellum. Okay? And another way of thinking about them is stay there. But the one that starts the movement is a burst of neurons. Okay? It's in the brainstem. And that is called burst neurons. And that is responsible for the eyeball to start moving. First gear. Okay? So that is known as go there neurons. So the reason why I come up with these two phrases, go there and stay there, is because these two concepts, I can see, it's not, some of you may be losing it, because it's not easy to think about it. But it's better to remember that if I have to move the eyeball from this position to that position, what do I need to do? Go there. Then as the eyeball reaches the target, stay there. The go there is initiated by PPRF after taking the signal from the frontal eye field. The stay there is initiated by your cerebellum. Go there, stay there. Go there, stay there. Go there, stay there. If I want to move to this side, left frontal eye field says go to that side, but then the go there neurons will say go there. And then the cerebellum will say stay there. Okay? So if you understand that, you know how reflex saccades are generated. Because it's challenging for you to move the eyeball from this position, 0 velocity to maximum velocity, and stop at the right point. You need these characters involved. Okay? Now, if you understand that, now what we're going to do is to draw it out in the picture. So, go there neurons are in the PPRF, stay there neurons are in the cerebellum. Okay? Go there neurons, PPRF, stay there neurons in the cerebellum. So frontal eye field tells the go there neurons, first gear. Then the cerebellum will take over and say second gear, third gear, fourth gear, stop, stay there. Okay. Now, today what happens to me? I took too much phenytoin last night. I've got phenytoin toxicity. Okay, cerebellum is not working. So no stay there function. What happens to me? I'm looking at the back of the room. Okay, no problem. Because my eyes are steady. Right? Only my cerebellum is not working, which means stay there. I haven't gone yet. So there will be no nystagmus at primary position. Just now peripheral nystagmus, even primary position there was. So that's already a difference. When I'm not moving my eyes, nobody knows I've got cerebellar problem. Nobody knows I took too much phenytoin last night. Right? But then I decide to move my eye. My frontal eye field is working. No problem with frontal lobe, right? Phenytoin does nothing to the frontal lobe. Okay? So no problem. So my eyes are saying, let's move towards the lady here. Okay? Frontal eye field sends a signal to the go there neurons. Go there neurons are in the pons, not damaged by phenytoin. Intact. Go there neurons working. Perfect. So go there. I'm reaching that. I'm going towards her. But then now the stay there wasn't working. Our cerebellum is damaged. So what happens? Cannot stay. Okay, then I'm looking towards this. Now I'm thinking, oh my, I wanted to go there. So what happens? My go there neurons will fire again. Burst. Cannot stay. My frontal eye field says, hey, I wanted to look there. My go there neuron says, yes, I'm trying. Go there. But stay there, not working. Go there. Stay there, not working. Go there. Stay there, not working. So fast phase, slow phase. Fast phase, slow phase. So fast phase is in this direction. Now, I say, okay, since I can't look to this direction, maybe I try here. My left frontal eye field is working. My right, go there neurons are working. PPRF. But my cerebellum, still not working. Right? So what happens? Left frontal eye field says go there. Sends a signal to the PPRF. PPRF says go there. But stay there, not working. Go there. Stay there, not working. Go there. Stay there, not working. So, fast phase, slow phase. Fast phase, slow phase. Now where's the fast phase? Towards the door. Just now was here, towards the lady. Now it's towards the door. Gaze, dependent. I look to the left, pinch to the left. I look to the right, fix to the right. Right? When I look up, same thing happens. I'll be able to reach the target, but stay there, not working. Up. Up. When I look down, down. I can reach the target, but cannot stay there. Slow phase. Slow phase. Down beating. Up beating, down beating. Right? Just now we talked about. So, in whatever direction I look at, the nystagmus is in the direction of gaze. So, it's called gaze dependent nystagmus. But another name that we use in English for this is gaze evoked. Why gaze evoked? Because when I was looking straight at the door, nothing happened. Because I didn't evoke a gaze yet. But the moment I evoke a gaze, that's when the nystagmus comes. So gaze evoked or gaze dependent nystagmus. This is classic of cerebellar disease. Why? The pathology is in the stay there neurons. Stay there neurons are damaged because the eyes cannot stay there. That is the mechanism of central gaze evoked nystagmus. Okay? So, just to complete this story, so this is what happened in this lady. She's got cerebellar disease. So when she looks to the right, beats to the right. Central position, nothing. When she looks to the left, it beats to the left. If she looks up, you would have been beating up. Look down, it's beating up. Just completely different from your peripheral nystagmus, which wasn't gaze evoked. Number one. Number two, always same direction. Number three, mixed horizontal rotatory. And then finally, Romberg sign. This lady, eyes open, eyes closed, put the glasses on, no glasses, same. Because nothing to do with the cerebellum itself is gone. So eyes open, eyes closed, just like your peripheral patients patients with cerebellar toxicity from phenytoin, for example. They'll come to you walking like this. Of course, when they close their eyes, it'll be a little bit worse. But difference is, the difference between eyes open and closed is very mild. Okay, so the same thing here. Eyes open, eyes closed, the nystagmus is almost the same. But just now, with the glasses on, no nystagmus. Glasses off, nystagmus. So that's from that side. So this is how you differentiate central from peripheral. This is very, very important for neurology, right? Because peripheral disease, we know, patients are very sick, but it's okay. They won't die. Nothing will happen to them. You can send them home. But cerebellar disease, they may not be looking very sick, but they can die on you, or they can develop major problem. So you need to take care of them. So to differentiate peripheral and central nystagmus is very crucial. So therefore, this is the most important lesson. Anything that changes direction, the nystagmus that changes direction will be central. And that is, the reason for that is because the pathology is in the stay there neurons for central disease. For peripheral disease, there is nothing to do with the eyes, it's got to do with the ear. The imbalance is never changing, it's always in 1 year, so there is no business for the direction of nystagmus to change. Okay, shall we summarize that?
Thầy cũng nói về cái mình vừa mới học về cái nystagmus mà gọi là gaze evoked nystagmus á, thì cái cơ chế của nó là do cái tức là về giải phẫu thì nó sẽ có hai cái cấu trúc, là cấu trúc ở trung tâm nhìn ngang ở cầu não, thì mình gọi nó là nó là cái trung tâm burst, tức là nó khởi kích cái cử động mắt nhanh, cử động saccade. Nhưng mà tuy nhiên nó chỉ là cái khởi kích thôi, nó khi nó nhận thông tin từ cái thùy trán đối bên á, thì nó sẽ khởi kích cái cử động đó. Tuy nhiên thì để nó biết chính xác và nó dừng lại đúng cái vị trí của cái saccade á, thì nó phải cần có một cái cấu trúc khác mà nó nằm ở tiểu não để nó kiểm soát cái cử động mắt nhanh đó, để nó đảm bảo rằng là cái cử động đó nó dừng lại đúng vị trí và nó không có đi lố hoặc là nó đi thiếu. Thì trong tình huống mà ví dụ như tổn thương tiểu não mà lan tỏa, chẳng hạn như là bị nhiễm độc phenytoin, bệnh nhân sử dụng phenytoin, bệnh nhân bị có hội chứng tiểu não, thì khi mà chúng ta test cái saccade của bệnh nhân á, thì nó sẽ có cái hiện tượng gọi là gaze evoked nystagmus, tức là khi mà mắt nhìn thẳng thì sẽ không có vấn đề gì hết. Tuy nhiên khi mà chúng ta đưa mắt bệnh nhân về một cái gaze có thể là trái phải hoặc trên dưới thì nó sẽ không, do cái tổn thương của tiểu não thì cái con mắt nó sẽ không có đi giữ được cái vị trí đó tốt, cho nên nó sẽ tạo ra những cái nystagmus mà chỉ xuất hiện ở cái khi mà chúng ta gaze, tức là chúng ta thực hiện chúng ta cho bệnh nhân liếc qua liếc lại hoặc liếc lên liếc xuống thôi. Thì tổng kết lại thì gaze evoked nystagmus thì có thể nó là một cái dấu hiệu gợi ý một cái bệnh lý trung ương, và nếu chúng ta so lại với những cái tính chất của bệnh nystagmus ngoại biên kinh điển thì chúng ta thấy là nó sẽ khác biệt hoàn toàn.
Your example about bilateral cerebellar intact were affected, but what happened if one side of cerebellar were infected? The slow wave show the opposite side of cerebellar. Is it?
So actually, you notice that in many cerebellar disease, pathology is bilateral because cerebellum is a central structure in a way. But sometimes you get unilateral pathology. So there will be some, because basically most of these inputs from the cerebellum is coming from both sides, right? So you don't get that much of directionality differences. But sometimes in gaze evoked nystagmus you get variation with regards to looking to one direction. It's much more obvious, right? Then that's because I've made it relatively simple, because you realize that the brain has got redundancy. Redundancy means there's extra labor to cover for problems. So what is NPH? It's a difficult name to remember, that's why I put it NPH. Nucleus prepositus hypoglossi. Okay, what is nucleus prepositus hypoglossi? It's in the medulla. Okay? Now, so for the rest of you, we don't have to remember this, but you realize that the stay there neurons are mainly in the cerebellum. But then you can ask yourself, I've seen patients with just pure lateral medullary syndrome, no infarction in the cerebellum, and they have a nystagmus that is horizontal gaze evoked. How do you explain that? Okay? The reason is the nucleus prepositus hypoglossi is a neural integrator that is present in the lateral medulla, okay, which has the same function as the cerebellar neural integration. So likewise, if you have a lesion in the pons, right, you often don't get horizontal gaze evoked nystagmus because there are no neural integrators in the pons. Okay? And later on when we talk about vertical movements, there are neural integrators for vertical movements. So if there's a pure lesion in the brain, stem in midbrain, then you may get vertical nystagmus, okay, neural integration problem for vertical nystagmus only. But when the cerebellum is affected, everything is affected. And often there's no directionality. Okay, both sides are affected. Okay, but one side may be more than the other because it's got bilateral innervation. So if you damage one side, the other side can compensate to some extent. Okay, but generally it will affect all integration. Look up, look down, look left, look right, everything will be affected if it's cerebellum. Okay, but then in the brain stem, you have additional neural integrators, stay there neurons, okay, which have additional function. And that's the reason why in brain stem you often get gaze evoked nystagmus also. But the reason is not so much the cerebellum being involved, often it is the cerebellum also involved because of the same vessels. But if it's a pure brainstem infarction, if it involves one of these structures, you can get. Yeah, so these are more likely to give you directionality. Like for example, left lateral medullary syndrome, you will find that the nystagmus is much worse when you look to the left. Look to the right, it's still there, opposite, it still follows the same in directionality, meaning look to the right, beats to the right, but less obvious. And that's because the left NPH is affected. Okay, so, but to keep it simple, just remember that the additional structures, which I didn't talk about, that are responsible for neural integration in vertical or horizontal movements. Do we need to know about that so much? Maybe not at this stage, but it's as you get more sophisticated in this science, then you need to know it. So this is basically the textbook diagram that you need to master if you really want to know this in detail. Okay, I hope I've not confused you.
Thầy vừa anh sĩ vừa mới hỏi là mình khi mà có gây nystagmus thì nó có khác biệt giữa một cái tổn thương một bên hay là tổn thương toàn bộ hai bên hay không?
Maybe for the rest, I would suggest that we just translate the part that says that the stay there neurons are mainly in the cerebellum.
Yeah.
So cerebellum disease is the predominant reason why you get, and there may be some, depending on which side of the cerebellum is affected, there may be difference in the amplitude of nystagmus, but we don't normally say left cerebellum, right cerebellum by then. We don't, because it's not accurate enough. Okay? But the point is, cerebellum is predominant monster of stay there function. It's a predominant monster, so it's responsible for everything.
Thì tức là ý của thầy là cái stay there neuron thì chủ yếu nó nằm ở tiểu não, và một cái tổn thương ở tiểu não thì nó sẽ gây nystagmus, mà mình cũng sẽ không thể nào định bên được rõ ràng. Nếu mà tổn thương ở tiểu não có thể là một bên, có thể là hai bên, thì nó sẽ không có cái tính định khu rõ ràng cho mình trái phải. Thì còn trong cái neurointegrator nó còn có nhiều cấu trúc khác nữa, nó có thể nằm ở medulla, ở hành não, hoặc là ở trên midbrain. Thì những cấu trúc đó khi nó tổn thương thì đúng là nó có thể nó gây ra một cái sự khác biệt giữa hai bên, thì lúc đó chúng ta có thể định khu được trái hoặc phải. Yeah.
Okay. So shall we take a break and come back at 10? So that everybody is a bit more awake. So 10 o'clock we start again. 20 minutes. Is that tea outside? No tea. No tea break. Huh? So
Finish at 10.
oh, is it?
Yeah.
Oh, okay, then shall we just continue then?
Yeah, just 5-minute break to let people digest.
Yeah.
Okay. 5-minute break. Okay. My suggestion is we do head thrust. No?
I think I asked around and they're glad to have 2 more dishes. They want to learn about people and skill deviation issue.
Yeah. So skill deviation is a bit more complex, so it'll take a bit longer. I can do it, but I think I should finish this. Yeah, I think it will be useful for you because you want to finish the HINTS. So this is a lady with left vestibular neuronitis. You notice the VOR is normal. Why is the VOR normal? Even though she has got no left, that's because you know we have 2 kinds of eye movements, voluntary and reflex. So DOLS is reflex, right? Voluntary is pursuit. This is voluntary eye movement. So what is this movement? Different from saccade. Saccade is move from one point to another very fast. Pursuit is follow the object. So pursuit requires vision. It's voluntary. It is not reflex. It requires vision. So if you don't believe me, you close your eyes and you try to do pursuit. 0. Close off all the lights and there is no pursuit also without vision. But saccades you can do in the night. You can do close eyes, you can do saccades. Okay, saccades and pursuits are different. Pursuit requires you to see the object and follow. Okay? So, if the left vestibular is not working, okay, you can overcome it with pursuit, because pursuit is this. But if you fix the object, this can also be pursuit. So, vestibular ocular reflex in a person who's in ICU, who's unconscious, no pursuit, only VOR. So you can do this head movements like this, no problem, because he's unconscious. But if you're conscious, the left vestibular system is not working, what will you do? You will use pursuit to continue following the object, because this is also pursuit. Just like this is pursuit. So, when as pursuit fail, turn off the lights. Can't see. Close the eyes. But then, once you close the eyes, you can't see. Turn off the lights, you can't see. So what do? Think about the other weakness of pursuit. What is the weakness of pursuit? It has to be slow. If it's fast, pursuit will fail and will be replaced by seconds. So, if you want to remove pursuit from this equation, what do? Don't move the head slowly, move the head fast. And that is the head impulse test. Very simple. Okay? Move the head so fast that only the VOR can work. If VOR doesn't work, it has to be replaced by saccades. In a conscious patient, you cannot use slow eye movements, slow head movement, because the pursuit is working. But in ICU, in a comatose patient, slow movement is no problem because there's no pursuit. So you don't need to do head thrust in ICU, but in emergency department, you must do head thrust to know whether your vestibular system is working. Why? Because head impulse is an important sign for the HIMSS protocol. It tells you the pathology is the ear, not the cerebellum. Okay? So, this is a lady with left vestibular disease. Left vestibular disease. So you notice the slow head movement, she is able to compensate with pursuit. But the moment I move the head fast, you see the difference? To the left, when I move the head fast, she cannot cope with the eye movement, so her eyes are following the head, and then she realizes, oh, I'm supposed to look there. Then she brings the eyes back. That saccadic correction tells you the left ear is not working. On the right side, no problem. She looks at you. Left side, eyes follow the head, then she makes a correction. So you have to learn to move the head. Can I show you? So head impulse test requires you to move the eyes, the head, okay, fast, slow amplitude. You don't need to twist the head, just a little bit, but fast. Okay, and you have to ask the patient to look at your nose, and for one moment you realize, oh, she's not looking at my nose, and then, oh, now she's looking at my nose. Then you know it's positive. So I'll show you the other way. So this is, imagine he's looking at the door. So this is head impulse to the left, head impulse to the left, this head impulse to the right. Okay? Now you can start practicing with each other, but when you start practicing with your neighbor, you realize that often you do this. So the reason is because you are afraid of moving fast, because you worry about the neck. So you have to practice a bit. So from here to here, okay, and stop. Then come back to the center again. From here to here, stop, and come back here again. Now, in the beginning, when you are not sure about the head movement, I've got a suggestion to you. When is the head thrust negative? When the eyes are looking at you all the time. So if you look at me now, this is normal. Okay, but this is abnormal. When I'm not looking at you, it looks like I'm not looking at you. Whenever you feel, oh, why is the patient not looking at me? It's abnormal. Okay? So that direction of movement is the ear that you're testing. Remember that. When I move my head to the left and your eyes are still looking at you, that's normal. When I move my head to the right, I'm not looking at you, that ear is not. If you remember that, you won't get confused. Then, to make it easy for you, I teach you a shortcut. Don't start from the center, because you are afraid of moving too much and damaging the neck. So you start from the end point. Okay, now you start from the end point, patient look at the door, and you come to the center. Much easier to bring to the center. When you bring to the center, you are not so afraid. So your hands are much more smoother, much smoother. So From here, you do this. This is for the right ear. From here, this is for the left ear. And when it's abnormal, when you feel, like for example now, I move from here to here, eyes go in that direction and come back. Go in the direction, come back, then you know that ear is abnormal. But when I test from here, it's normal. But this one is moves and comes back. Then you know that ear is abnormal. Okay? So you can practice this way. This is for the right ear, this is for the left ear. Okay? So I give you 5 seconds, or not, 30 seconds. Turn to each other and practice doing it. Okay, important test. Okay, remember to move small amount. When you come from the side to the center, okay? See, both are same. Because the physiology is the same, it's just your position. So both are same. Okay, so this is the basis of the Etra sign. Okay, let's see whether you all can recognize the pathology. Which side is abnormal? The right, huh? Yeah. So whenever you see that the patient is not looking at you, it's abnormal. So left is normal. He's looking at you. He's looking at you. Now, he's not looking at you. He's not looking at you. So right abnormal. What about this one? This is more difficult now. We saw that lady just now. To the right. Very subtle, right? Looking at me. Very subtle to the right. Remember her nystagmus was beating to the left just now? So her right disease, that's why he's beating away from the disease. Okay? Okay, what about this patient? Both sides. So he's got bilateral vestibulopathy. Okay? Which is not an important disease, but no, not a common disease, but important. So after meningitis, both ears are deaf. Both ears, no vestibular system. So bilateral atras. Too much aminoglycosides. Amikacin. Both ears gone. Right? Because amikacin levels only tell you about kidney. Doesn't tell you about this. So patients get bilateral vestibulopathy. Right? And they will not have nystagmus because nystagmus means one side must be abnormal and the other side is normal. Here both sides gone. So no nystagmus. But very, very unsteady, very giddy. So you will say this is psychological until you do the atras. Then you realize actually it's not psychological, both ears gone. Very severe disease. These patients are miserable because when you close the eyes, you will fall. When they shower, when they are putting soap on the eyes, close the eyes, boom, fall. Because everything is dependent on eyes. So remember to pick that up. Okay? Okay. So now if you want, you can go to skew deviation. But skew deviation is a bit tough. Okay? So I need you to understand. So skew deviation means one eye is up, one eye is down. Okay? If you want to just remember it that way, that's enough. Okay? One eye is up, one eye is down. So you sit the patient up like this. One eye is down, one eye is up, one eye is down. Okay? So this is vertical deviation of the eye. Now, why can't we just call it vertical deviation of the eye? Because vertical deviation of the eye can be due to fourth nerve lesion, can be due to myasthenia, can be due to thyroid disease, right? We don't call it skew. We call it skew only when there is vertical deviation of the eye due to brainstem disease. Then we call it skew. Okay? So what is the basis of that? Well, you need to understand a few things. So you saw just now, this man is clearly skewed. One eye is up, one eye is down. Dr. Nia, do I have to stop now?
No.
I continue. Okay.
Yeah, let's continue.
Okay. So one eye is up, one eye is down. Correct? One eye is up, one eye is down. So how do you explain that? Okay, so this guy, this is something that I want you to pay attention to, okay? Now, remember, he only had a lesion in the medial longitudinal fasciculus. How do you explain medial longitudinal fasciculus? You can explain adduction problem. But why does one eye go up, one eye go down? What else is traveling in the medial longitudinal fasciculus to make your eye go up and down like this? There must be something, right? So that's when you have to understand there's more to the medial longitudinal fasciculus. Okay? More to the medial longitudinal fasciculus, because what happens is you have something called the semicircular canal like this, but there's also utricle and saccule. Do you remember utricle and saccule? What's utricle and saccule? Okay, when you go to the lift just now and get into the lift and you press the button, okay, you're going towards the 14th floor for breakfast. Now let's say you don't look at the 14th number. Do you know you're going up? How do you know? Utricle and saccule. You feel yourself going up. When you come down, you know you're coming down, not because you're looking at the number, because you're utricle and saccule. So these are gravity sensitive receptors in your inner ear. Okay? So this input has to go to your eyeballs. Why? Because your eyeballs have to move according to the gravity. So if I move my head to the left, what happens to the vestibular ocular reflex? Okay, when I move my head to the right, what happens to my eye? My left eye moves this way, right eye moves this way, right? Correct? Now, when I move my head to this side, what happens? What happens to my eye? This eye intorts, extorts this eye intorts. Correct? You look here now, you see? This eye extorts, this eye intorts. Sorry, this eye intorts, this eye extorts. I move my head to the other side, this eye extorts, this eye intorts. So, I will not get confused by, because just because I move like this, everything doesn't turn this way. Everything comes back to normal. So I know the vertical is vertical because my utricle and saccules are sending signals up the medial longitudinal fasciculus and telling my eye to this way, this way, this way. When I move this way, this way. Okay? Now, let's say now, okay, both sides, utricle, saccule, signals going up to the medial longitudinal fasciculus to my third and fourth nucleus to make my eye go this way. Okay? Now, remember, if I have a lesion on the left MLF, signal from the right side is not going to the, signal from the right side is not going. Okay? So now, when I turn my head to the right side, this side goes this way, this side goes this way. Correct? When I turn my head to this side goes this way, this side goes this way. But now my head is steady, but this side signal is gone because the MLF is blocked. So no signal from this side, but signal is coming from the other side. So what does the brain think? Oh my God, my head is turning this way. Right? When my head turns this way, what happens to my eye? One eye will turn right, the right eye will extort, the left eye will intort. That's number one part of skew deviation. Right eye will extort, left eye will intort. Because the input from one utricle and saccule is not coming through, the other side is coming through, just like your peripheral nystagmus. Okay? The utricle and saccule is going to confuse your brain and make you think that your head is tilted to the left, but your head is not tilted to the left. Your head is steady, but your eyes will tilt as if your head is tilted to the left. So skew deviation. Number one component of skew deviation is tilting of the eye. But then we haven't explained up and down. Because one eye goes up, one eye goes down, right? Now, for us, when we move the head left and right, what happens to the eye? It goes this way, right? But before we became humans, our eyes were to the side. Right? Most mammals, the eyes were to the side, and then subsequently the eyes came to the front. So in the previous evolutionary paths, our eyes were to the side. So if you're a rabbit and you want to tilt your head this way, what happens to this eye? It's going to go up. This eye is going to go down. And then it's going to get confused. Oh my God, why is my head? So what does it do reflexly? This eye will come down, this eye will go up, so that it can continue to run like this. When it tilts this way, this one will go up this way. That's the rabbit. But we are not rabbits. We have come to the front. So we have suppressed the vertical component. It was there before, but we have suppressed it. Now, have you heard of other things that we have suppressed? There are many things that we have suppressed. For example, this man has got advanced HIV dementia. Advanced dementia. See what happens when I put my hand to his mouth? He will start kissing me. See? He starts going towards my, like a baby. And did you see his hand? He gripped my hand. So in dementia, the previously suppressed grass reflex, the pout reflex, the rooting reflex, all comes out. So in neurology we know that when disease of the central nervous system happens, the newer layers are destroyed, the older layers come up. Because grass reflex is very primitive. Because we were monkeys, right? We were going from tree to tree. So we had to have grass reflex. But for humans, we cannot have grass reflex because you cannot let go of your tool, right? Your hammer or whatever tool. So we lost it. But when you have stroke, dementia, grass reflex, you won't let go of his hands. Similarly, babies have this rooting reflex, right? But we have lost it. Why? Because as we grow more mature, it is suppressed by the nervous system. But when you have disease, like this man, I put his hand up, he's doing this, right? So the same way, when you have disease in the central nervous system, the rabbit reflex comes back. If you are a rabbit, when you turn your head to this side, this one will go up, this one will come down, this one will go up, right? Turn your head this way, this one will come down, this one will go up, right? So in brainstem disease, you become a rabbit again. So what happens is, if my head is turned to this side, my right eye was extorting, left eye was intorting. Turn my head to this side, my left eye was extorting, left eye was intorting, right? As humans, right? So now we say, because of the MLF lesion, the input from the right utricle and semicircular canals was not going up. So it looked like this side was active, this side was inactive. So it looked like my head is tilting to the left. So what happened to my eye? Right eye extort, left eye intort. Correct? Correct? Everybody okay, right? But then we also realized that we have become rabbits. For rabbits, when my head is tilted to the left, what happens? Right eye will come down, left eye will go up. Right? Remember the rabbit, when the rabbit is running like this, when it tilts this way, it will do this. Tilt this way, it will do this. Right? So now it's not tilting this way, the input is not coming from here. So it will behave like it's tilting this way. So this eye will come down, this eye will go up. So one eye is up, one eye is down. Component number 2 of skew deviation. So this eye is extorted. Okay? Sorry, this eye is intorted, this eye is extorted, because now it looks like the head is tilted to this side, right? So this eye is extorted, this eye is intorted. Okay? And then this eye is going up, this eye is coming down. Component number 1 is the turning. Component number 2 is one eye up, one eye down. Component number 3 is Now, if I suddenly feel my head is steady, but suddenly I feel that the world is tilted towards the left. Remember, this side the signal is not coming through. I am conscious, right? So what will I do? I will sit. I will balance myself by moving my head to the opposite direction. Right? So component number 3 is head tilt. So 3 components of skew. Head tilt to one side, one eye is lower, one eye is higher. Higher eye is intorted, lower eye is extorted. All 3 can be explained by remembering that your signals from your utricle and saccule are responsible for your position of your eyeballs, okay, and remembering that we were rabbits in our previous generation. Okay, so that is basis of skew. I told you it's a bit difficult to understand, but we can go through it again. But basically, this is the diagram to explain it. Okay. So the signal from one side, utricle and saccule, is blocked. So the other side, you feels like there's too much signal from this side. So if there's too much signal from this side, what happens? My right eye must extort, my left eye must intort. If I was a rabbit, this eye will go up, because remember, okay, this eye must go up, this eye must come down, right? This eye will go up and this eye come down. And because now it feels like my whole world is tilted to this side, even though I'm steady here, I will compensate by moving my head towards the opposite direction, so that the angle will look same. This is exactly what I'm showing here in this picture. If you start seeing buildings like this, what will you do? You will shift it the other side so that the building will look straight, right? So that's why the patient's head is tilted. So now if you go back to this patient, you realize he's got a lesion that's coming from the left side of his utricle and saccule and going up the medial longitudinal fasciculus. So making him look like this side is not working. So this side is working too much. So this eye is higher because this eye is intorted, this eye is extorted. Correct? Okay, and then the head is tilted to which direction? For him, which direction is it tilted? To the lower side. Okay? So this tells you that the problem is in the brainstem, where the connections from the utricle and saccules are traveling up from the medulla all the way up to the midbrain. So any lesion along the way will give you a skew. Okay, the skew can be this way or the other way, depending on which side is affected. But the moment you have a skew, you know it's brainstem. And the skew has got 3 features. Head tilt, one eye, the lower side of the eye will be lower towards the side of the head tilted. One eye will be higher, the higher eye will be intorted, and the lower eye will be extorted. If you see this combination, you know for sure it's a skew deviation. Okay? Now, skew deviation is dependent on gravity, right? Gravity. So that means gravity is the one that's telling your ear, I tilt this way or more input. This side more input. So, if you were to make the patient sit, he's sitting and lying down. Okay? Now, skew deviation is dependent on gravity, right? When you lie down, both eyes are balanced out. No difference. So the semicircular canal, utricle saccules cannot make a difference. But when you stand or sit, there will be a lot of difference. So skew deviation, like in this picture you can see, okay, the bottom picture is lying down. In the top picture, you can see. In the bottom picture, is lying down. In the top picture, is sitting. You can see the difference. So skew deviation is always worse when you sit the patient or stand. So when you see in HINTS, after you've done the head impulse and you've confirmed the nystagmus is peripheral or central, you sit the patient up and you see if one eye is up, one eye is down and head is tilted, then you know this is skew deviation. And you will know for sure because when you lie the patient down flat, it's not so obvious. Okay? Why is this important? Because as I told you before, some eye doctors will see this in fourth nerve lesion. What happens in a fourth nerve lesion? Superior oblique responsible for making the eye go up, right? Down. So when it's weak, what happens to this eye? Goes up. But what happens to the higher eye? It is extorted. In skew deviation, it is intorted. So the eye doctors can help you differentiate between skew deviation and fourth nerve by looking for two features. One, skew deviation is worse when you lie down. Fourth nerve doesn't make a difference whether you lie down or sit up. And the second thing is, in skew deviation, the higher eye is always intorted because of what I just showed you. But fourth nerve is responsible for looking down and intort, right? So when it's weak, it goes up and extorts. So it's the opposite. So this is what will happen if the eye doctors look in the fundus. Superior oblique, the fundus will look like that. Skew deviation, the fundus will look like that. So the eye doctors can help you differentiate that. If we use a direct ophthalmoscope, it's a bit more difficult, right? But if with the indirect ophthalmoscope or through the slit nerve, they can differentiate that easily. Okay, very important, right? Because fourth nerve lesion will come acutely. And then the eye doctors will be wondering, is this skew? Skew, I must send to the neurologist for stroke. Right, brain stem. Fourth nerve, peripheral lesion, leave it alone. Right? So that's why this is important. But for you, okay, the most important thing to remember is, remember the head impulse, the nystagmus. Then if you see, if the patient is sitting up, you can get the patient to sit. Just see what happens to the eye. One eye high, one eye low. Okay? That's enough. You don't need to go through all of what I just talked about today. Okay? But this is to make you understand why there is this thing. But if you see one eye up, one eye down, in a person who's got vertigo and central nystagmus and no head impulse test, stroke. Right? So that's what you need to recognize. Don't need to go into all the things I talked about today. Like, so this man, clearly when he sits up, one eye is up, one eye is down. And his nystagmus is peripheral, no, central. Head impulse is negative. So his vertigo must be central. So when we scan him, we find an eye no lesion. Correct? So that's the logic of using the skew deviation. Okay? Now I'm going to pause to translate and then we'll take some questions.
Thì thầy vừa mới giảng về cái skew deviation. Thì mình biết là skew deviation sẽ có 3 thành phần chính. Theo thầy thì có 3 thành phần chính. Thành phần thứ nhất là nó sẽ có cái sự xoay của con mắt. Thì giả dụ như mình có một bệnh nhân bị tổn thương, cụ thể là cái giải phẫu của nó là nó đi từ cái xoang nang và cái cầu nang và nó đi theo cái bó dọc trong để đi lên trên các cái trung tâm của dây 3 và dây 4 trên trung não. Thì nếu như có tổn thương bó dọc trong, giả dụ mà có tổn thương bó dọc trong thì nó sẽ làm cho mất cái tín hiệu đi từ xoang nang và cầu nang lên trung não, thì khi đó nó sẽ dẫn đến các cái thay đổi trên nhãn cầu. Cụ thể là ví dụ như có tổn thương bên trái thì sẽ khiến cho bệnh nhân cảm giác giống như là nghiêng về bên trái và nó sẽ xoay con mắt, cả hai mắt phải thì sẽ xoay ra ngoài, mắt trái xoay vô trong, và cộng thêm cái chuyển động là một mắt nó sẽ đi lên, một mắt nó sẽ đi xuống. Thì và thêm cái thứ ba nữa là nó sẽ có cái hiện tượng là bệnh nhân sẽ nghiêng đầu phản xạ, tức là bệnh nhân cảm giác như bệnh nhân nghiêng về một bên, bệnh nhân sẽ nghiêng về cái bên tổn thương. Như vậy thì mình sẽ có 3 cái thành phần của cái skew deviation. Một điều là phân biệt giữa một cái skew deviation và một cái liệt dây 4 đơn độc ở một bên. Thì chúng ta biết là liệt dây 4 thì nó sẽ kéo con mắt nó sẽ trôi lên trên. Tuy nhiên trong skew deviation thì con mắt nó sẽ xoay vào trong. Còn ngược lại trong cái liệt dây 4 đơn độc á, thì con mắt nó sẽ xoay ra ngoài. Thì đôi khi mình sẽ khám lâm sàng thì mình sẽ khó phân định nó, nhưng mà bác sĩ mắt khi mà họ dùng cái soi đáy mắt hoặc là họ khám qua đèn khe á, thì họ sẽ dễ dàng nhận định được là con mắt này đang xoay vào trong hay xoay ra ngoài.
Okay.
Anh có câu hỏi gì không?
We've still about 10 more minutes, so the others can back up. Actually, I don't need the computers. You can ask them to back up the projector also. Because the last bit I want to go through is different type of eye movements, and then we can stop, which is this one.
Sir, how to examine extortion and intortion?
Okay, I'll
without
go through
the lens?
Intortion, extortion, I'll go through again. But actually what I wanted to go through without the computer is So I don't need, you can tell him to back up. We can just discuss.
Em ơi, em có thể dọn đồ được.
So this is see, what I will do after explaining that again is this. This one doesn't need slides. Classes are eye movements. Okay? This picture. Okay, you can take a picture of this. Remember we talked about saccades, pursuit, VOR. These two we haven't talked about. So I'll explain the logic of it, but this is the definition. Okay? So we have 5 types of eye movements. You'll be wondering, oh my God, I didn't realize there's so many eye movements. There are 5 different types of eye movements, all done by the eye. Okay, and we'll explain that in a minute. We don't like also. Okay, and if you have to leave, please go ahead. So, the skew deviation, I'll explain one more time. Okay, so remember, utricle, sacule. Okay, utricle, sacule. I'm a rabbit now. I'm not a human being, I'm a rabbit. Okay, so if I'm a rabbit, what happens is, as I'm running like this, I tilt my head to the left. I shouldn't be looking into the sky. I shouldn't be looking into the ground. Automatically, this eye must come down, this eye must go up. If I turn my head to this side, this eye cannot be looking into the sky, looking to the ground. It must come down, and this one must come up. That is one component that has become suppressed in us because our eyes went to the front. When it's in the front, when you move left or right, you shouldn't go up and down. There's no need to go up and down, right? There's no need to go up and down, right? So it can stay still. But the torsional component remains. So when I move my head to the right, this eye will intort, this eye will extort. Okay, when I come back, I'll come back to center again. Now when I move to this side, this eye will extort, this eye will intort, right? So that it's just like when I move my head to this side, right eye abducts, left eye abducts. When I move to this side abducts this side. When I look down, go up, look down. Actually, all this is mediated by 4 structures altogether. Semicircular canal, superior, horizontal, posterior. So when I tilt my head back, posterior canal very active. Okay, so my eyes will look down. When I tilt my head down, superior canal very active, my eyes will look up. Okay? Then when I tilt my head left, this the canal is very active, my eyes will go opposite direction. When I tilt my head this way, this canal very active, my eyes will go the other way. When I tilt my head sideways, utricle will pick up the gravity and will make my eye extort, this one will intort. When I turn my head this way, utricle and sacule will say gravity here more than that. So my eyes will go this way and this way. Okay? But in our evolutionary past, our eyes were not here, were here. So when I turn my head this way, my eyes must also come down and this one must go up. When I turn my head this way, my eyes must come down and this one must go up. So when there's disease affecting the right side of my ear going through my left MLF, because the signal from right side crosses the MLF and goes to the opposite side. Now, if the signal coming from the right side is damaged, so the left utricle, sacule, semicircular canals all more active than this side. So when I'm standing still, this side is going to make it look like I'm tilting my head to the left because this side is no signal. So although my head is steady, I'm thinking my head is tilted to this side. So what will happen? My eyes must extort, this one must intort. Number 1 component. Number 2 component, we were rabbits. Okay, if I was a rabbit, if my head is tilted to the left, this eye will come down, this eye will go up. Because remember, when I tilt my head to the eyes will be one eye up, one eye down. So it will be very confusing. So I will bring it down. So even though my head is steady, this one go up, this one come down. Component number 2. But now my brain is thinking that there's no input from here. My whole world is tilted to this side. So I feel like I'm going to fall to this side. So what will I do? I will balance myself by moving because I feel like I'm going to fall this side. So I'll go to this side and compensate. So head tilted to the opposite side. This eye is lower. This eye is higher. The higher eye is intorted. Lower eye is extorted. That is the skew deviation. Okay. So if you work it out each time through remembering your semicircular canals and remembering that we were rabbits in the past, just like your grass reflex. You know, why does a grass reflex come back when you have a stroke? Why does your Babinski come back when you have a stroke? Why does your pulp come back when you have a stroke? It's because of our evolutionary path. So if you remember that, you can work it out very clearly. Okay?
So what is the logic behind we try to alternate between covering each eye when we try to test for skew deviation? What is the logic?
Yeah. So you don't need to, if it's very obvious, you don't need to. You'll be like that lady, it's very obvious, right? But some people, because skew deviation is reflex, right? So a lot of people have very mild deficits and they are compensating, right? When you compensate, when you close one eye, and then the other eye has to fixate, the weaker eye will come down, the higher eye will come down. Then you close this one, the lower eye will go up. So you want to see this movement. So this is a trick that the eye doctors always use to pick up subtle difference in eye movement. So similarly, whenever we do abduction deficit, sometimes the abduction deficit is very obvious. No need to do cover test. But you see the eye doctors sometimes, they want to pick up mild deficit. So they will make the patient turn to this direction. Patient says double vision. But when you look, the eyes look the same. But when you cover this eye, poof. When you cover this eye, poof, moves. Then you realize, oh, there was a subtle difference in the left and right eye. I can only see it when I cover the eye. So the cover test is to bring out subtle differences in the axis. Most neurologists don't need to use that because most of the time, very obvious. Right eye not abducting, left eye not. No need to use cover test. But they often see patients with very subtle differences and they want to pick that up. Okay? So the same way, the skew is obvious like these two patients. You saw the two patients I showed you? Very obvious, one up, one eye. No need to do cover test. But some patients will come to you, they look very, very mild. It's normal. Then you do the cover test, poke, 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 poke. When you see the vertical movement, you know there is a subtle skew that the patient is compensating by using his other muscles. So you want to unmask the compensation. Because the compensation, basically you know what it means, right? This eye is thinking, oh, the other eye is not moving. Let me move my muscle harder. But once the other eye is moving, not shown, then the eye says, why must I work so hard? I relax now, poof, it goes up. So that's why we use the cover test to unmask the compensation that's happening in the eye. Because the compensation is the Herring's law. Remember Herring's law? Yeah. So we are trying to unmask it. And that's what we do. So cover and cover test. But most of the time not necessary. Okay? Okay. So we'll finish off with the eye movements. Huh? So 5 set eye movements. Very easy. Now, if I walk into this room, okay, you realize that I look at you, I know who you are, right? I know who you are, I know your color, your shirt, color, everything. But in the periphery, I see Dr. Tree is there, right? But in the periphery, I know he's Dr. Tree because I know he was sitting there. But I can't figure out his color of the shirt because it looks black and white to me. And I can't figure out the shape. I can't figure out whether he's wearing glasses or not. You know, I can't. But the moment I bring my phobia, I can see everything now. So you realize you can do the experiment now. All of you look at me now and try to figure out what's happening in the surrounding. You realize first of all no color and very, very poor acuity, almost like 660. So vision is actually lousy in the periphery, only good in the fovea. So if you are a hunter, you are looking in the jungle and you want to hunt something, right? When you are looking at something, you don't want to, you need to, if you see some movement like Dr. Tree is shaking his leg, right? I know he's shaking his leg, right? Because the peripheral vision is very good for movements. But the moment I see the movement, I don't want to run towards it because I go there, it may be a lion. The lion may eat me. Right? So what must I do? I must bring my phobia very quickly. Why must be very quickly? Because the animals in the jungle, they're moving very fast. So I have to bring my phobia very fast. That's why cicadas have such sophisticated speed. You have to bring it very fast and then suddenly your phobia will know, oh, this is a lion. Better not run. This is an antelope with a broken leg, separated from the mother. Oh, I'm going to succeed in this hunt. So I better chase. Right? So that amount of visual acuity can only be brought upon by a phobia. Okay? So that's why we need cicadas. Has to be fast. Okay. But once I track the animal now the animal will be very far away. I don't want to chase him. I want to wait till he comes close to me. But along the way, he's going to jump into the forest, He's going to go in behind the trees, he's going to behind the, and I will lose him. How will I lose him? Because if you notice, all of you can do this experiment. Look at me now and look at the computer's table. In between, you would have realized you didn't see the screen. So saccades are very fast, but you become blind in between saccade. So if you are using saccade to track an animal, you will lose the animal, right? Because you can't see in between point A and point B very fast, but in between you lost it. So you need something to keep your phobia on the target. So that's a very sophisticated challenge. So if you talk to your engineer friends, the same technology that guided missiles use, which is keep the phobia on the target. And is the target moving fast, you move fast. If it's moving slow, you move slow. That is called pursuit. And the pursuit is similar to your finger pursuit, you know, your finger nose test. That's why when your finger nose test becomes irregular, in cerebellar disease, your pursuit becomes irregular. Because your cerebellum is a key motivator or generator of pursuit. Because it's very challenging. You have to keep your phobia on the target. The target moves fast, your phobia must move fast. Target moves slow, must move slow. Target move up, must move up. And must do some AI-like intelligence. It must know how fast the thing is moving, and from it must predict where it's going to be in the next few seconds. Cannot just follow, right? So it's intelligent. So the pursuit is a very highly sophisticated movement. So then you pursue the object until you know you are close to the animal. Then you run after the animal, right? But when you're running after the animal, you want to make sure your phobia is on the target, right? But to keep the phobia on the target, if you use a frontal eye fields, what happens? Your frontal lobe is used to keep your eye on the target, but your frontal lobe is not used for planning. So everything is look at Dr. Tree, look at Dr. Tree, look at Dr. Tree. Then I don't know what to say to him. But if I use a reflex to keep my eye on the target by using my VOR, I move my head left, move my head up, every time my phobia is on the target. Then I don't have to use my frontal eye fields. So VOR is brilliant. Because I can move my head left and right, I can jump, I can climb the tree. Always my phobia is on the target, right? So VOR was the third eye movement we evolved. Then we have something a bit more complex called optokinetic. You all know optokinetic? So optokinetic is when you're on the way back home today, you sit in the train or the car and you look out the window, your eyes are looking at the window, right? As you're relaxing, your eyes will automatically move to the next scenery, next scenery, next scenery. Why? Because as I'm chasing him, my scenery is changing. I don't want to be, I want to be aware that there are trees coming. There is a hole there is a drain, there is a pond. I need to know. So I need to keep my scenery current. So we have evolved a fourth set of eye movement called optokinetic, which is coming from your parietal lobe, which moves your eye automatically. Okay, we don't need to go into so much details about that, but that's the fourth set of eye movement. The final one is the most recent one that we evolved. When I jump on him, I need to go for his jugular. Okay, and jugular means I need to know three-dimensional. So three-dimensional, you need to do what? Superimpose one eye with another eye. Just like your 3D glasses, you have to superimpose. So what do you need to do? Converge. So the last set of eye movements, that slide I gave you is vergence, convergence. So 5 set of eye movements that we use. Okay? In the next 1 week when we meet again, when we talk about other eye movements, we will talk about how knowing these eye movements is very useful, because when you are supposed to be using pursuit, and then instead of using pursuit, you use saccades, like just now, right? We know something is wrong with the mechanism. Sorry, I'll start again. If that particular movement is not working, for example, when you move the object very slowly in front of a patient, you're supposed to be using pursuit, but instead you use saccade. Then we call it saccadic pursuit. That means the pursuit is not working. Why is the pursuit not working? maybe patient not looking at the object, not interested. Okay, he's not looking at the object. But if he's looking at the object, why is the pursuit not working? Cerebellum. Because the cerebellum needs to work. So when the cerebellum is not working, the brain doesn't go on strike. It says, okay, let me use saccades. But the problem with saccades is poop, 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 poop. So I show videos of patients with cerebellar disease where the pursuit is not working because of the cerebellum, the saccade. The saccades take over, and therefore you will know this patient has got cerebellar disease. Likewise, this is just the end. After this, this is the... When I move my head, normally you and I, we don't move our head like this, right? We don't do this. What do we do? When I want to look at the tree, I move my whole head there. Head movement, head saccade. Now, if my VOR is very active, right? So what will happen when I move my head like this? My eyes will be stuck on you. Right? So normally when you and I are moving around, we don't move our saccades like that, we move our heads. But when we move our heads, our VOR is always active, right? So if a VOR is active, what's going to happen? My eyes will be stuck there. So who must turn off the VOR? Cerebellum. So the cerebellum is brilliant. It knows, oh, you're going to look at the tree. Better turn off the vestibular ocular reflex, otherwise the eyes will be stuck there. So the cerebellum will program a stimulus exactly equivalent to the enough to cancel the VOR. So it's called VOR cancellation. So in cerebellar disease, I'll show videos later, we show patients where the VOR cancellation is abnormal, like what he's showing. So for example, here I need VOR cancellation for my eyes to be fixated on this. But if I move my head like this and my eyes are moving all over, I'm not able to cancel the VOR. If I'm not able to cancel the VOR, that means when I move my head like this, my eyes are stuck there. That means who's not working? Cerebellum is not working. So in other words, the reason why we learn these 5 eye movements is because we know these 5 movements are physiological function. So when they are not working, when they are supposed to be working, we know there is pathology. Because somebody else has to come and take over the role. If he is supposed to do the work, but he is not there and you are doing the work, that means something is wrong with him, right? That day he's sick. So that's why we know the 5 movements. So when cerebellum is abnormal, instead of pursuit, we use saccades. When the cerebellum is abnormal, the VOR cancellation is gone, right? So that's how we learn. And just now we gave an example, right? When the VOR is not working, you move the head so fast, only saccades can cope for it. So by using the presence of a saccade for coping, we know the VOR is not working. So the head impulse is another example of how we use our knowledge about eye movements to understand pathology. Okay? Okay, we better stop now because it's past the time, right?
Yeah.
This is my certificate. I'll keep myself. Thank you. Okay, guys. Thank you. See you in Ho Chi Minh City.
Yeah. Thank you so much.